Pulmonary embolism usually results from thrombi, often from the deep veins of the lower limbs or pelvis, which are transported via the right heart into the pulmonary vasculature. Large emboli may cause obstruction to blood flow and result in life-threatening hypoxia and high mortality. Pulmonary embolism should therefore be managed as a medical emergency. The risk factors and management for pulmonary embolism are very similar to those for DVT, that's the vein thrombosis. And the causes, just like DVT, include stagnation of blood in the vein, increased viscosity of blood, and inflammation of the blood vessel causing damage. Symptoms are dyspnea, pleuritic pain, cough, hemoptysis due to pulmonary infarction, presyncope, syncope or collapse, as in massive pulmonary embolism, and also unilateral swelling of the limb. The signs that are usually elicited include tachypnea, tachycardia, which may be regular or irregular. Blood pressure may be low or unrecordable, which suggests massive pulmonary embolism, and it could be normal or even high. Pleural effusion may be present, and also low oxygen saturation on pulse oximetry, usually less than 90%. There could be pleural rab, cyanosis, and also unilaterally swollen calf or thigh of DVT, deep vein thrombosis. Wells scoring for pulmonary embolism probability. If there are symptoms of deep vein thrombosis, give 3 points. If there are no alternative diagnoses, better to explain the illness, you give 3 points. If tachycardia with pulse more than 100 beats per minute, you give 1.5 points. And if mobilization is greater than or equal to 3 days, or surgery in the previous 4 weeks, you give 1.5 points. And if there is a prior history of deep vein thrombosis or pulmonary embolism, give 1.5 points. If there is a presence of hemoptysis, we give 1 point. Presence of malignancy, give 1 point. So let's look at the interpretation of the Wells score for pulmonary embolism. So the score greater than 6, that indicates high probability of pulmonary embolism. With a score greater than or equal to 2 but less than or equal to 6, that's moderate probability. The score less than 2 is low probability. For low probability, D-dimer test is recommended. Moderate or high probability, D-dimer test with additional CT pulmonary angiogram is recommended. Okay, investigations: chest X-ray, ECG, D-dimer, CT pulmonary angiogram, echocardiography, Doppler ultrasound of the affected limb and pelvis, and also FBC. Treatment objectives are to stabilize cardiorespiratory function, to prevent further clot formation and embolization, to prevent recurrence and development of pulmonary hypertension. Non-pharmacological treatments include elevate affected leg on a pillow if deep vein thrombosis is present, and also apply compression stockings after pain subsides if DVT is present. Also, for surgical techniques, some include embolectomy, inferior vena cava valve filters, among others. Pharmacological treatment. For clinical suspicion of pulmonary embolism, first line treatment, you give oxygen by face masks or nasal prongs or via non-rebreather masks, and you keep oxygen saturation greater than 95%. And also you give morphine IV 5 to 10 milligrams stat, and also enoxaparin So for enoxaparin SC, adults we give 1.5 milligrams per kilogram. That's 150 units per kilogram daily. Or dalteparin SC in adults, 200 milligrams per kilogram, with a maximum dosage of 18,000 units daily. For warfarin oral, give it simultaneously, but it's not recommended in pregnancy. And for adults, the loading dose for day 1 you give 10 milligrams, day 2 10 milligrams, but day 3 you give 5 milligrams, and then you check the INR. Continue 5 milligrams daily, INR, until a target INR of 2 to 3 is achieved. After this, the low molecular weight heparin is stopped, and a maintenance warfarin dose of 2.5 milligrams to 5 milligrams is continued. Some patients may require 7.5 milligrams. So this is continued and is guarded at all times by targets INR of 2 to 3. And long-term treatment requires continuation of warfarin for 3 to 6 months, and if the risk factor is temporary or unknown, you continue to. So recurrent embolisms and permanent risk factors such as thrombophilia requires long-term anticoagulation. Referral criteria: so refer all patients with suspected pulmonary embolism where facilities are unavailable for confirmation to a physician specialist or even a cardiologist for expect management after stabilization.